I would like to thank all of you for being here. It's a pleasure and an honor for me and for the Catalan Society of Neuropsychology to introduce Professor Heaton, distinguished professor of psychiatry in the University of California in San Diego. We really appreciate you have accepted our invitation in a very tight period of work for you. So we really thank you. Professor Heaton has been the president of the International Neuropsychological Society and the Clinical Neuropsychology Division of the American Psychological Association in the past. He has received the National Academy of Neuropsychologists Award for his important contribution to the field. Most of us have known him from the Wisconsin card sorting test manual and from the computer version of it. In his long and productive career, he has worked in several fields with a special contribution in the neurocognition neurocognitive normative standards for classifying CNS dysfunction, neuropsychology of schizophrenia, effects of neurocognitive deficits on everyday life, HIV-associated neurocognitive disorders, and cross-cultural neuropsychology for studying neuro-AIDS in non-Western countries. Nowadays, he is the director of the neuropsychological components of large multidisciplinary research programs regarding neuro-AIDS and schizophrenia. In this conference, he is going to talk about psychometric issues in neuropsychological assessment within and across cultures, a very interesting topic for the clinical assessment and also for the research in a globalized world. Finally, I'd like to thank the contribution of the neuropsychology section of the Col·legi de Psicòlegs de Catalunya to make possible this lecture. Oscar Pino is the head of the neuropsychological section, and he will act as a discussant in this conference. So, Professor Heaton, go ahead. For sure, everybody is going to enjoy your presentation.
Well, thank you, Sylvia, for that kind introduction, and thank you for inviting me. It's a pleasure to be here. I'm going to be talking about psychometric issues, and particularly about the development and use of norms in neuropsychological assessment, knowing full well that Spanish neuropsychology has made a lot of progress in this area in its own right. But hopefully my experiences in this area in the US and with our international collaborations, especially in the HIV area, will be of some interest to you. So these are the three main purposes of neuropsychological assessment. First, we use our tests to detect and classify, characterize neurocognitive deficits associated with various kinds of central nervous system disorders. We use our tests to measure change over time. That would be deterioration with a progressive illness, or improvement with treatment, or with spontaneous recovery after an acute insult to the brain. And we use our tests to identify important strengths and weaknesses of our patients as they relate to their everyday functioning, so that we can plan rehabilitation and help compensate for problems that they have in their daily lives. I'm going to talk mainly about these first two, actually exclusively about these first two. The third one is a different talk. So Back in 1997, the Psychological Corporation, for the first time, published a new version of the Wechsler Adult Intelligence Scale and Wechsler Memory Scale that were, for the first time, co-normed. And so this allowed for a number of advantages. One, you could more accurately compare scores from one battery to another. And also, it permitted the test developers to do factor analytic work to figure out what cognitive constructs are measured by the two batteries together. And these are the six constructs, which I think are probably very familiar to you, but briefly, they are verbal comprehension, perceptual organization, working memory, processing speed, and both auditory and visual episodic memory. I was on the neuropsychology advisory team for the Psychological Corporation for the WAIS-3, WIMS-3, and and they allowed our group to develop the demographically corrected norms. So I have the data, and I will be presenting some of that to you today to help establish some points. So this is the standardization sample of the WAIS-3. There's 2,312 people. The demographic characteristics are below. The oversample happened because the neuropsychologists really encouraged the Psychological Corporation to include more ethnic minorities and people with lower education level, so we could work with them in our norms development. That 276 people you see are very different, especially with regard to education level, and also the full-scale IQ was almost two thirds of a standard deviation lower than for the entire sample. For the WIMS-3, we have the same situation, but it's a much smaller sample because the Psychological Corporation sells many more intelligence tests than memory tests. So I'm going to quickly go over some of the demographic effects that we found in the US on these 6 factors. Here, the y-axis is education-corrected z-scores, and on the x-axis we have age from 20 to 85. And you see that there's a trivial linear effect of age on verbal comprehension, although in terms of nonlinear effects, there's some very slight improvement in with age and subgroups up to age 45-ish, probably due to additional learning that goes on, ideally. And then at the end of life, there's there's some very slight decrease, but the linear component has a R-square of less than 1%. Very different for perceptual organization. Quite a linear effect and quite substantial with an R-square of 27%, processing speed 45%, very steep and linear pattern. Working memory 24, auditory memory 20, and visual memory 45 again. So visual memory and processing speed are the two most age-related factors. And not surprisingly, they're the two factors that are most sensitive to general kinds of brain disorders, which I'll present data on in a little bit. So moving on to education, we divided the sample into 5 education groups, 0 to 8, 9 to 11, 12, which is high school graduates, 13 to 15, some college, but no degree, and 16 plus people with at least a college degree. And on the y-axis, we have age-corrected z-scores. And you see that whereas verbal comprehension had very little age effect, it has a very substantial education effect as expected, with an R-square of 32%, and it's quite linear. Perceptual organization, 18%. Processing speed, 17%. In the WIMS-related factors, we see something a little different from the strict linear relationship, whereas in the less than high school groups, they're kind of flat and low. There's a big jump at education 12, and then there's a gradual increase beyond that, and that's what you see in all of the WIMS-related factors. So here's auditory memory showing the same, and visual memory. Okay, so we have been talking about the effects of age and education in terms of effect sizes, which is a little bit abstract. But so what happens if you ignore education in your classification of abnormality or impairment in people? And the next slides are intended to show that. So these are on the these are age-corrected z-scores, and the y-axis is percent people of normal people misclassified as impaired. And we have our 5 education groups, with the orange being 0 to 8, yellow 9 to 11, pale yellow is high school, and green 13 to 15, and dark blue 16 plus. And the whole purpose of norms is to level the playing field so that people have the same probability of being correctly identified as normal if they are old or young, if they have high education, low education, male, female, or no matter what their ethnic background may be. You can see that this is not the case here, that there are gross discrepancies in the misclassification rates. And especially the people with less than high school education are have unacceptably high false positive error rates. You see that the high school graduates are about where you expect with a 1 standard deviation cutoff. About 16% is what we're looking for. And then the people with some college or college degrees are way lower. And you might think, well, that's great for the people who have the college. But in fact, it's not great, because you expect to see about 16%. If you see a lot lower than that, what it means is that you're applying a normative standard that is too low for your group. So when you go to apply that to people who may have brain disorders, you're going to be much less sensitive in detecting them. So we want them all to be the same. That's the goal. So you see the same thing for the WIMS-related factors. Now, moving on to sex. We don't, the effects are more subtle, but they're still there, and they can be very important. Here we have age and education corrected z-scores for males in green and females in pink. That's appropriate, right? So on the verbal comprehension factor and perceptual organization, the males in green have lower false positive error rates, so they're doing a little bit better. On processing speed, females do much better. And then in working memory, males are a little better, and both auditory and visual episodic memory, females are much better. And if you put those two together and make it into, as the Psychological Corporation did, a general memory factor, and use the same normative standards for males and females, you call twice as many males impaired. So it can be important. Now, in the U.S., and I think in most industrialized countries, minority status comes with it a lot of factors that can be disadvantageous in terms of developing cognitive abilities, including lower socioeconomic status, lower access to high-quality education, less access to high-quality health care, nutrition, and so on. So it's very, very complicated. But regardless of the complexity of it, we as neuropsychologists still have the potential and I think the obligation to, with our norms, try to level the playing field so that people with different ethnicity backgrounds can, again, have the same probability of being correctly classified. And this shows with age, education, and sex-corrected Z-scores, the percent misclassified for these three ethnicity groups, non-Hispanic white in red, African American in green, and Hispanics in yellow. And what you see is that there's a grossly unfair misclassification rate for the African Americans if you use the same norms. And you see the lowest classification rate in non-Hispanic whites, and in the middle is the Hispanics, but the Hispanics are much more like the non-Hispanic whites. And here you see the same thing for the WIMS factors. And then when you go and correct for everything, then it does level the playing field so that you get the same rates of impairment across all three of these groups. Okay, moving on to a different battery of tests. Another battery that I've worked with a lot is an expanded Halstead-Rayton neuropsychological battery, which may not be in much use here, but and it's not important to talk about the details of that. It's a very lengthy battery, takes 6 to 8 hours to administer. But this, I'm going to show you some results from the normative samples. There are 1,212 people with Caucasian and African American ethnicities. And I'll also show data from 436 people with structural brain lesions due to mixed etiologies to show you some sensitivity, specificity information. Okay, so the average impairment rating, the AIR, average impairment rating, is a summary score from the core Halstead-Rayton battery where high in raw scores on the left is bad, and you have the normal people in green and the brain damaged people in red, and they're broken up into 3 age groups: young, less than 40, middle age, 40 to 59, and older, 60 plus. And here, with the raw scores, what you see, the slopes represent the age effects, which are quite substantial, and they are pretty much the same for the two groups. And then the difference between the red and the green is, of course, the brain damage effect. So there's an age effect, a brain damage effect, and no interaction. And when you move over to the right, where you have fully corrected T-scores with mean of 50 and a standard deviation of 10, and high for a T-score is good, you have your normal people here with a straight line, no age effect. They're all around 50 where they should be. And then the same brain damage groups are down here, and their mean T-scores are from 1 to 1.5 to 2 standard deviations below the mean. So they're pretty straight lines, and so you're seeing here on the right just no age effect, but a big brain damage effect, and that's what we want. Here we see the same thing for education. We have 3 education levels here: less than 12, 12 to 15, 16 plus. You have the normals with a steep slope, the brain damaged people, another steep slope, about the same slopes, and here's the brain damage difference. And over on the right, you have 2 parallel straight lines, pretty much, just showing the brain damage effect, which is what you want. So why am I talking about using a 1 standard deviation cutoff to classify, quote, impairment? There are two reasons. One is that the annoying fact is that there is an overlap between the cognitive test performance of people with known brain damage and people off the street with no history of trauma or disease involving the brain. So there's no place on a neuropsychological test score continuum that you can pick and say and get all of each group right. So you have to make a choice. The second reason is that there is a trade-off between sensitivity and specificity. So when one goes up, the other one goes down. Again, you have to make a choice. One thing you can do with T-scores, though, is you can make a better informed choice because you know exactly what your probability of being wrong is, at least in the specificity area. So this is a cartoon that shows what I've just been talking about. On the top frame, there are two normal distributions. There's the normal group in green, and there's the impaired group in red, and there's an overlap, and there's no place that you can pick on the T-scores that gets them both all right in both groups. So here's the one standard deviation point, and you can see in this cartoon at least, it provides the best balance between sensitivity and specificity. Now, there are situations where you wouldn't want balance in sensitivity and specificity, and that's we could discuss that later. But I think in general, it's good to have that balance in most situations. Now, down below, it shows what happens if you move the cut point from one standard deviation below the mean to two standard deviations, and you pick up a few of the normals there, modest improvement, but you lose half of your brain damaged people. So it's a bad trade-off, I think. That was a cartoon, but this is real data of 1,212 neurologically normal people in green, and again the large brain damage group in red. And you see it looks a lot like the cartoon. There's an overlap. There's no place that you can find along the T-score axis that gets everybody right. And the best cutoff for balancing them is right here. 40 is right in the middle there. Moving back to WAIS 3, WIMS 3, if we do if we take the standardization sample with complete data on everything, and we take a group of mixed clinical cases that were reported on in the WAIS 3, WIMS 3 technical manual, you can, and apply different cutoffs to demographically corrected scores, you can see what happens when we move the cut point from one standard deviation to 1.5 to 2. And on the one standard deviation cutoff, you see that the specificity is held pretty much where it's supposed to be at 83 to 85%. And when you do that, then you can look and see what's the sensitivity of when you hold specificity constant, you can compare the sensitivities. And you see that the lowest sensitivity, not surprising, is verbal comprehension, and the highest are processing speed at 74% and visual memory at 83%. The important thing is, though, what happens when you move from 1 to 1.5 to 2? Well, you pick up a modest amount on specificity, and you lose a lot in sensitivity. And if you get to 2 standard deviation, you're not missing hardly any of the normal people, but you've missed most of your clinical cases. And that's, again, I think a very bad trade-off. Okay, so we've been talking about what happens with a one standard deviation cutoff on a single measure, but we don't give a single measure. We give a lot of tests to be comprehensive in our assessment of our patients. So it's pretty obvious that the more tests you give, the more likelihood people are going to screw up on something. And that's everybody in the room except for a few of you, not me. But this is what actually happens with the Halstead-Rayton battery. All these people had at least 25 measures. And on the x-axis, it's the number of measures that people were impaired on at the 1 standard deviation level. And it goes 0, 1, 2, 3, 4, et cetera. And on the y-axis is the percent of normal subjects that are there. So only 13% of normal subjects were normal on everything using that cutoff. And in general, people were screwed up on about 10% of the tests that we gave them. So it's not just finding an impairment on a battery. What matters is the number of impairments, the severity of those impairments, and the pattern of those impairments as they relate to expected effects of the diseases and injuries that we are studying or evaluating clinically. So you see here the same thing with the way swims, and here there are only 6 scores, and even with the way swims, only 55% of the normal people were normal on all of them. And it turns out that in order to be really unusual for normals, it's right, the cutoff is right here over 2. In the clinical sample, obviously very different, but there are more people with and there are more people in the higher ranges of numbers of impairments, but there is definitely overlap. So then if you move on to the, what happens if you do greater than 2 impairments? Well, you misclassify 13% of the normative sample, and you get 72% of the clinical sample, and the sensitivities are different for the different disorders shown here. Okay, so one approach that we've used to identifying impairment on a big battery of tests while controlling for multiple comparisons is called a global deficit score. And it intends to do what a clinician does. It looks for the number and the severity of impairments on a test battery and kind of puts less weight on good things. When we look at everyday functioning, we're particularly interested in good things, but when we're looking for disease, we're paying more attention to bad things. So what we do is we take the demographically corrected t-scores and we say, okay, everything from 1 standard deviation below the mean and better is normal. So that's a deficit score of 0. And the percent of normals that get that are about 85%. Then, somewhat arbitrarily, we called mild impairment t-score of 35 to 39. 8.6% of normals do that. Mild to moderate, 30 to 34, t-score 4%. And once you get beyond that, normals very rarely do it. So it's almost a pathognomonic indicator of a problem. So what we do is we assign one of these deficit scores to every test in the battery, and we add them up and divide by the number of tests, and that's the global deficit score. And what we found with numerous batteries with different populations of clinical people and normal controls is that the best cutoff for impairment is 0.50. That number or higher indicates significant impairment. And what that translates into is that, on average, the people that are classified as impaired by the GDS are at least mildly impaired on at least half of the things we gave to them. So it's a pretty conservative indicator. And this shows what happens with t-scores on these brain damaged people with complete data on everything. For full-scale IQ, you get a sensitivity of 52%, average impairment rating 75%, and global deficit score 91%. Okay, moving on to measurement of change. When we give our tests a second time or a third time or a fourth time to anybody, we don't expect to get exactly the same result because our tests are not entirely reliable and our people are not entirely reliable. And when we give tests a second or subsequent time, people in both groups tend to do somewhat better because of their learning with the previous exposures. So we need to figure out how much of a change is a real change that may relate to improvement or progression of illness. And I'm going to move on to talking about HIV from now on. And just briefly, I'm sure all of you know some about the literature of neurocognitive impairment in HIV, or HAND, it's called, HIV-associated neurocognitive disorders. But maybe some of you are not working in this area, so I'll give a little bit of an introduction. That HIV gets into the central nervous system very rapidly after infection, and ultimately in some a third to half of people will develop HAND at some point during their illnesses. You probably also know that in 1995 there was a revolution in the approach to medication treatment of HIV using powerful combination antiretroviral strategies. And one of the questions that we wanted to ask here was, so what did this change do to HAND, to central nervous system effects? And because we've been working with the same tests and the same methods for 25 years now, we had data that went back that far. So here's data from almost 1,800 people that are divided up into pre-CART, before 1995, and post-CART. And they're divided up into HIV-negative controls and 2 HIV-positive group, non-AIDS and AIDS. So this shows in yellow the pre-CART groups, negative controls, non-AIDS, AIDS, and the y-axis, the percent that are showing impairment. In the HIV-negative controls, we see about the impairment rate that we expect with a 1 standard deviation cutoff. And there's a nice stair step, a little bit increase with non-AIDS, and then a big increase or an equally increase in AIDS. But pre-CART, you see about the same thing for the negative controls and for the AIDS, but for the non-AIDS, it's actually worse. And the reason for this is that the non-AIDS people, because of the better treatment that they're getting, they're living much longer with less physical illness than they used to. So these are like 4 to 5 times, they've lived 4 to 5 times as long with at least low-level infection in the central nervous system and exposure to very strong medications, some of which can cause toxic effects on the brain. So HAND has not gone away. It's still there, even though people are living a lot longer and having better lives in other ways. So what happens when you follow people with HIV over time? Are they changing? Do they all go downhill? Does some go downhill? Does some get better? And so what we had a national collaborative study where we tested some 1,700 people, finished the testing in 6 sites all around the United States. And we finished the testing in 2007, and then we followed up a smaller group, 438 people. Because of funding issues, we couldn't afford to test them all, follow them all. And this group was averaged of 6 testing sessions over an average of 36 months. So there were 2,680 visits altogether. And this is our HIV test battery, and the specific tests are not important, but they're all tests that have been found to be sensitive to HAND. And they include tests of verbal fluency, attention and working memory, processing speed, executive function. There's Wisconsin there. Learning, delayed recall, and complex motor functions. So here, again, what we're trying to figure out is how much of a change is a real change. And we need to account for such things as practice effect, regression to the mean, so the people that did worse to begin with may show more of an improvement the next time, and vice versa. We need to consider the baseline functioning and the test reliability and other things. So we developed regression-based norms for change, and they're published. And using potential predictors, the first two of these were always the most important. First is the baseline or the prior visit test score for the individual on the individual test that we're talking about. And the second thing is overall neurocognitive competence, which is defined as the average score on all the other tests we gave them other than the one that we're looking at. Okay, so if on the one you're looking at, the person did worse than how they did on the other things, they may show more improvement. And if they did better than they did on the other things, they may show more decline on that test. So it's an individual regression to the mean. And then we considered test-retest interval, which is surprisingly not very important. And then we considered demographic factors. So what we did is we did the multivariate regressions, predicting follow-up scores on each of the individual tests in the battery with the non-changing group, with the standardization group. That yields a formula that you can use to predict the follow-up score from all the things that I talked about. And you you subtract that predicted score from the observed score, divide by the standard deviation of the residual, and that gives you a z-score that reflects how well or how badly the person did on that test relative to normal expectations for somebody who isn't changing. Then we average all those z-scores, and that's a summary regression-based change score. And following tradition and nothing else, there's no real empirical basis for making this decision. Psychologists tend to use a 90% confidence interval. So we call 5% at the low end as they're decliners, and 5% in the upper end are improvers. It could be that 80% is better, or even 70% with 15% on each tail, but that's what we did because that's what people are used to. So this shows the distributions of those summary regression-based change scores, time 1 to 2, 2 to 3, 1 to 3. So they're pretty well behaved psychometrically, nice normal distributions. And this is what happened to our HIV-infected group. 23% got worse, 61% stayed the same, and 17% improved. And we found that there were a lot of disease-related and some non-disease-related factors that predicted from baseline predicted change. And then we did survival analysis to see, to look at time-dependent changes. So if a person went on treatment or off treatment, if a person's health status in various ways went up or down, they could be predictors. And we found a lot of those predictors being significant in the expected direction, always, excuse me, with worse medical changes being associated with worse cognitive changes. And then this just shows that whereas the three groups were about the same, this y-axis is average t-scores at baseline, about the same at baseline, at the end, they were quite different. Their outcomes were very different. So then we did multivariable predictors of decline. Our four independent, most powerful predictors in the model was very significant, were if they went off antiretroviral treatment in a time-dependent way, they were at much higher risk for impairment. If they were more immunosuppressed at that time, that they were at higher risk. If they had a greater baseline non-HIV confound, so if they were learning disabled, if they had had prior head injuries, strokes, if they were substance abusers with serious overdoses, all those kinds of things. They were rated as, their comorbidities were rated, and that was used as a predictor as well. And then finally, something we didn't expect in the beginning was Hispanic ethnicity. But in the US, Hispanic ethnicity, because a lot of the Hispanic people are fairly recent immigrants and a lower SES in general, there is a literature that shows that Hispanics there are more likely to have their HIV detected later. They're more likely to be later to get treatment, and their long-term outcomes from a medical point of view are worse. And what this shows is that their long-term outcomes from neurocognitive, in terms of, we're talking change here, we're not talking baseline, is also worse. So I have a junior faculty member who just got a 5-year grant to study that more carefully, especially in older Hispanics with HIV. Okay, moving on to international studies. This map shows all of our international collaborations, and we have all the names are gone. Sorry, Jose. Anyway, all our international collaborations, and every place that there's a star shows where our test battery and our test procedures are being used. So we have collaborations, we're fortunate to have collaborations in virtually all of the continents. So this is our international test battery that's a lot like the other test batteries that I've shown you. Wisconsin is up there again. And this shows the focus of the research has always been on HIV, and the biggest groups are always the HIV infected, but we've tried our best to find resources to test HIV negative controls, and this shows where we are with in these different places. So Anhui is a very poor agrarian rural Chinese, mainland China province. Yunnan is a more wealthy, more urban place, a province in southern China, Hong Kong, India, Zambia in Africa. And these all have fairly decent HIV negative control groups, but in Brazil, Romania, and South Africa, very small groups. They're well matched to the HIV positives, but they're not sufficient to do individual norms for any of those places. And this shows what happens if you apply US norms to the different ability areas in all those places. And you see the green thick bar up here is the US people hanging right around 50 where they should be. And most of the other places, with the exception of Hong Kong, which is doing very well in most areas, are lower. That's one thing. And another thing is that the patterns are different as well. So it's not like you could add a constant and bring everything up and use US norms. You can't do those things. And this is a very busy slide, I apologize, but it's just some recent data we put together from our Zambia work. These are the test scores on the test measures on the left. Then these are black Zambian normal people, and we've applied here the African American norms to see how well they work. And on the US T-scores, you see that almost all of them are too low. That's one thing. Another thing, though, is that they're not low to the same degree. There's a lot of variability there. And on the right, you see also a lot of variability, but that this is the percent of Zambians that are classified as impaired using African American norms. And for the global battery, it's 62%, which is horrible. In the middle, you see, we asked the question, well, okay, so that the US norms call too many Zambians impaired, but do they at least get rid of the demographic effects or improve the demographic effects? And here you see that in many cases, the first number is the demographic effects on the raw scores, and the second number is the demographic effects on the US T-scores. And you see that the T-score demographic effect is less in many respects, and overall it's 37% for demographics in the raw score and 18% for the T-score. Okay, it's a little bit better, but it's not better enough. And there are some that actually are worse. And that's because the US norms may overcorrect or for some demographic factors, like especially sex. And in the US, women are better than men in a lot of ways, as I talked about. In Zambia, though, being a woman in Zambia goes with it a lot of disadvantages. Polygamy is still possible there, and women don't get the advantages in the family that men do, and it shows up in differences in cognitive test scores. And if you use the US norms where women do better, then you make things worse from a normative point of view. And so this, again, shows the percent of people in all these places that are called normal people, that are called impaired by US norms. Hong Kong is doing very well, but none of these other places is doing well. But if you look at if you get an effect size for HIV using the people, using HIV negative controls from the different places where we're studying it, we find significant effect sizes everywhere. So HIV affects the brain and cognition everywhere. And the differences are not great. This one from Brazil, again, they had a very tiny HIV negative comparison group. And the effect sizes are generally in the medium range. So the tests themselves are okay, but they need their own norms that are appropriate for the populations that you're dealing with. And unfortunately, that's an expensive and time-consuming endeavor, but we're trying to do it. And this shows the percent of people impaired in these places where we have really good norms, and these places where we don't have such good norms, or where we're using norms from someplace else. So the tests are good, norms are important. How to use norms can be complicated, but I think it's interesting, and I hope you enjoyed hearing about it. This is the UCSD, this is my university library at night. Thank you.